is currently on the board of directors. And now again, he's obviously working with us, which is great. He's been helping us a lot with patients who have muscle-related pain. And I think one of the key experiences for Norman probably was when he trained, and I'm sure he's going to talk to us about that more in detail, when he trained with Hans Krauss, who was an orthopedic surgeon who practiced in New York for about 50 years. He died in the late 90s. Hans Krauss was a believer in muscle as a primary source of neck and back pain. And Norman spent several years with him training on muscle-related pain. Now, Hans Krauss was a very particular character, and I happened to be in Lake Placid last week with my family climbing and hiking, and I met several individuals, climbers and patients of Hans Krauss, who were all had a history in Olympic skiing and coaching ski teams and so forth, who live in Lake Placid. So I met two individuals last week in Lake Placid who knew Hans Krauss and talked about him very enthusiastically. And Norman will tell us a little bit more about Hans Krauss's philosophy, his approach to pain, to back pain. Norman, I'll hand over to you. You'll talk about muscle and overlooked cause of spinal pain. Thanks for being here this morning.
Thank you very much, Roger. Good morning, everyone. And the introduction has already been made, so we'll move right into it. And it's really striking that we can put a man on the moon and we can decipher the genome, but we still can't understand the source of persistent back pain. And I'm going to use as a template for the talk a patient who is referred from the Spine Center, PG, a 43-year-old lawyer and an avid weightlifter with bilateral shoulder and neck pain with radiation into his right arm. And he subsequently had surgery, and his preoperative CT showed a C3-4 herniated disc and a left foraminal stenosis. And his history went back to 2017 when he had the onset of neck and interscapular pain. The MRI of the cervical spine at that time was negative. He had physical therapy and trigger point injections with no effect. In 2019, with continued and progressive pain, he had a repeat CT and minimally invasive spine surgery was performed, but unfortunately with no change in his pain. He had Botox, which was ineffective. He had a facet block, which produced a 50% reduction in pain, but the radiofrequency ablation was a failure. So we've been interested in soft tissue as a source of pain at the Spine Center, and that's why I was offered to come over to teach on the faculty. And I myself and two neurosurgical fellows, Franzi Schmidt and Sertak Kernak, did a review of the literature in 2019 with search words spine surgery, back pain, and muscle tissue. And we looked at 2,700 articles. And of the 2,700 articles, 3 articles mentioned muscles as a source of pain in patients who had spine surgery and had persistent pain. 2 of the articles mentioned the multifidus muscle, and 1 article, however, in the French literature, stated that muscles were a major source of persistent post-MISS pain. So it's really striking because muscles are the largest organ system. Striated muscles are the largest organ system in the body. There are 320 paired muscles and 1 unpaired muscle for 641 muscles. And muscles are a key component in terms of the supposed source of pain in chronic and acute low back and neck pain. And in a study of approximately 25,000 ambulatory patients in 1995, which was published in 2001 in New England Journal of Medicine, Deo and his group, the diagnosis for 70% of the cases was non-specific or idiopathic low back pain. Can somebody mute their was non-specific or idiopathic low back pain, which is defined as sprains and strains of soft tissue. The 30% remaining had 39 other diagnoses. At 3 months, it's even more striking because the symptoms, the pathology, and the radiological appearance are poorly correlated, and pain is found to be nonspecific in about 85% of chronic patients. And I'm referencing these statistics, and all of the references are available at the end of the talk. Most of these patients end up in pain treatment centers, which are mostly imaging driven. And we know that the #1 treatment given is epidural steroid injections, facet injections, radiofrequency ablation with successful facet injection, sacroiliac joint injections as well. There are other treatments that go on. However, most of it is imaging driven. Bob Zimmerman, who many of you may have known, who was the director of neuroradiology at Cornell, in 1997, published an article in a journal where I was the guest editor, and he said, in our practice, neuroradiology at New York Hospital, less than 10% of spine MRI examinations are interpreted as normal. Therefore, it's not possible to always determine whether abnormalities seen on the imaging study are responsible for the patient's symptoms. In terms of the cost of care for neck and back in the United States, in a study of 23,000 responders between 1997 and 2005, the cost of care went up $32 billion. It was a 62% increase from 1997 to 2005. And what's very striking is that in that same period of time, the number of patients who were impaired with neck and back pain went up 25%. We spent 32 billion more, and 25% more patients were disabled. In that same study, the diagnoses were analyzed, and between 1997 and 2005, there was a 100% increase in the way the MRIs were being read, with spondylosis 100% more often seen in 2005 than 1997, a 40% increase in intervertebral disc problems, and a 40% decrease in sprains and strains. So despite the fact that we see clinically the largest number of patients with back pain is nonspecific, the diagnoses in terms of the imaging studies are reducing the number of cases that we are defining as coming from sprains and strains, and actually producing more targets for injections and block. Essentially what we're doing is focusing on the bony spine, the neuraxis, and the spinal cord within and the exiting nerves, and ignoring the soft tissue that overlies the bony skeleton. If muscles can be a common source of pain, why are we ignoring them? Well, one reason is the pathophysiology is rarely studied and no discipline owns muscle. And in addition to that, deciding on which muscle in a region of the body is the source of the pain is challenging for a number of reasons. One is localization specificity, the other is muscle layering, and the third is peripheral entrapment neuropathies. And I'm going to go through each one of them separately. We remember from medical school days the homunculus, and the homunculus, as the body represented in the cortex, has no torso. So if a patient reports that they have pain in their buttock, it may be really talking about their low back, and if it's low back, it may be buttock, because the density of innervation is much less in the torso than in the periphery. We see that muscles are layered, and if we had pain, let's say in this thoracic paraspinal region, it could be tender because of the trapezius on the superficial layer, the rhomboid beneath, the spinalis, the longissimus, the iliocostalis lumborum, the splenius capitis. Any of these muscles could be the source of pain. And so if we're using palpation to identify which muscle is the source, rather than just a spot somewhere in the body, we want to know a specific muscle because the density of nociceptors is in the muscle attachment. If we don't know which muscle it is, we can't know where the origin and insertion is. And we can have nerves that traverse muscles, that penetrate the muscle, come around the muscle, and a muscle that's tight or swollen or in spasm can squeeze these nerves, for example, coming from the lumbar plexus, and give us what looks like a radicular pattern going down the leg that's actually not coming from the neuraxis, but rather from the peripheral nerve being squeezed and perhaps leading us to think that the problem arises from the herniated disc or bulging disc or other pathology that we see on the imaging. But what about the pathophysiological mechanisms of muscle pain? Because muscle is a source of pain. It's not just a reflection of nerve compression elsewhere. Muscles have nociceptors, and they are mechano and chemo nociceptors, but for the most part, the nociceptors that we find in bench studies are polymodal, that they respond to both mechanical and chemical stimuli. They are group 3 and group 4 fibers, which are analogous to the cutaneous A delta and C fibers that we know about so well. We call them group 3 and group 4 because their concentration of substance P and calcitonin gene-related peptide is less, because it wouldn't be good for the organism if there was the same amount of calcitonin gene-related peptide and substance P, because there would be more swelling involved. So therefore, God was smart in creating muscle nociceptors. They are receptive free nerve endings, and they're activated by noxious stimuli. So the stimulus has to be strong enough where there's potential tissue damage, where the tissue damage has already occurred, meaning that there's a high threshold to produce stimulation. And when we stimulate the fiber, and here's the schematic of a group 4 fiber, and we can see that these fibers are in association with the arteriole next to the muscle, not the muscle fiber itself. And there are varicosities on the group 4 fiber. And these varicosities contain multiple neuropeptides such as substance P, calcitonin gene-related peptide, cholecystokinin, somatostatin. And when the fiber is stimulated by a noxious stimulus, chemical or mechanical, it releases these substances from these varicosities, which in turn stimulate mast cells to release histamine, and the histamine dilates the vessel. From the vessel wall, we get prostaglandins, and from the plasma, we get bradykinin, and from the platelets, serotonin. And these chemicals create a neurovasoactive soup that can continue to re-stimulate the group 4 fiber or group 3 fiber and get a long-lasting stimulation, which will travel in an anterograde fashion back to the spinal cord. However, the nerve itself, the group 4 fiber, can be compressed somewhere proximally, and from the point of compression can give an action potential that's retrograde, going back to the muscle and giving us the same phenomena as if we had noxious stimulation in the milieu surrounding the muscle. So we could get neurogenic inflammation or myogenic inflammation or myogenic pain, and it would be pretty much indistinguishable. For the most part, we think about pain that we see in a muscle as reflecting stimulation from the nerve, but actually, as we saw from the demographics, that most of the patients presenting with muscle pain have nonspecific, defined as sprains and strains of soft tissue, thinking that, of course, the pain is originating in the periphery. If the action potential from the compressed nerve goes anterograde, it's a neuropathic experience. So the group 4 fiber comes to the dorsal horn and synapses with the dorsal horn neuron. And initially, with the release of glutamate, the major neurotransmitter, attaches to the AMPA and kainate receptor with an influx of sodium, depolarization of the neuron, an action potential that goes up into the spinothalamic tract, and we can experience pain. And when this stimulus turns off, that it's a transient trauma, that the nerve repolarizes and we're back to a resting potential. But if we continue to stimulate the nerve, there's ongoing stimulation or repetitive stimulation to the nerve, it becomes sensitized, meaning that the threshold to produce an action potential is lowered. And there's a sequence that we see when we get peripheral sensitization. It's quickly followed by central sensitization with referral patterns from muscle to muscle and microglial activation. And as a modulating effect, we find diffuse noxious inhibitory control, which is now called conditioned pain modulation. And I'm going to go through each one of these separately. So peripheral sensitization is an increased excitatory response to all stimuli to these nociceptors. So since there's a lowered mechanical threshold now, any mechanical stimulus, even movement of the muscle, may cause pain, and we call this mechanical or muscle allodynia, because allodynia is pain to a non-painful stimulus, and therefore just mere pressure can be experienced as tenderness or pain. Something that is already painful, a typically painful stimulus like a pinprick, would be experienced as even more tender and more painful. And we can get spontaneous pain because the threshold is so low that we get resting activity discharges. Initially, remember that glutamate was released, but it did not affect the NMDA receptor. Initially, it was only AMPA and kainate receptors. But once the sensitization occurs peripherally, soon after, there is release of substance P, which heralds the onset of central sensitization and the opening up of the NMDA channels. And so we see initially glutamate is released to AMPA and kainate receptors. This is the NMDA receptor with the magnesium block. It initially is not stimulated, but with ongoing stimulation from the group 4 fiber, which is now sensitized, we get release of substance P, which attaches to a neurokinin receptor and in turn knocks out the magnesium block, giving us an influx of calcium ions, and along with that, phosphorylation of these receptors, which keeps them open. And now we have a persistent reduction in the resting threshold and clearly a lowered threshold to depolarize. When we have central sensitization, we have the phenomena of referred muscle pain. And the referral mechanism is of 3 sorts. There's an opening up of ineffective connections, which give us muscle-to-muscle referral patterns. We can have referral from muscle to other organs like joints, and convergence is the last reason for referred pain. There are multiple ineffective channels throughout the CNS. In fact, most of what's in the CNS is silent, and much of the work of a normal, healthy CNS is to suppress activity. When we have a muscle that is perturbed, and causes persistent pain, let's say, for example, muscle A is the infraspinatus muscle, and it is sensitized. When it is sensitized, the dorsal horn neuron representing the infraspinatus opens up an ineffective pathway to higher levels or lower levels in the spinal cord. In this case, let's assume that muscle B is the trapezius muscle. So pain in the infraspinatus muscle can be experienced as pain in the trapezius because of this connection through the ineffective channel. We see this often where a patient presents with pain in the trapezius and we inject it, let's say with trigger point injections or physical therapy, and no matter how hard we try, we may get some initial relief or suboptimal success, but it comes back and we keep on retreating that muscle over and over because it may not, in fact, reflect where the pain originates. When we have the opening up of ineffective pathways, we, in this case, in a rat study where they caused a myositis in the rat in the gastrosoleus muscles. The rat doesn't have gastroc and soleus, but it's one muscle combined. That muscle is represented by L4 and L5. So the afferents going back to L4 and L5 in a normal rat will only stimulate L4 and L5, but when the rat muscle is inflamed, L6 opens up, and L6 represents the sacroiliac region, so we can actually cause pain in the region of the sacroiliac joint that is originating in the gastrosoleus muscle. And the last reason with a referred pain pattern would be the two muscles can share the same afferent. And let's say in this case, muscle A was the infraspinatus and muscle B was the teres minor. They could share an afferent, and pain in one muscle or the other may be experienced in either of the muscles. When we have stimulation of the dorsal horn neuron and it's sensitized, we get stimulation of microglia. And the receptor on the microglia that is stimulated is toll-like receptor 4, and it's a pattern recognition receptor, meaning that molecular patterns will stimulate the production of cytokines. And if it's from cell damage or nucleic acid damage, they are danger or damage activated molecular patterns. And if it's from an organism like gram-negative bacteria, it would be pathologically activated molecular patterns frequently associated with lipopolysaccharides. And this stimulation causes cytokines and chemokines to be produced. But what's interesting is persistent pain will have the same effect. And we get stimulation of toll-like receptor number 4. And two of the cytokines that we're most interested in, which are pro-inflammatory cytokines, interleukin 1b and interleukin 6. And interleukin 1b causes the sickness response. So a patient may feel tired, down, somewhat anxious, and not interested in interacting. And this is a survival mechanism. The organism thinks it's damaged, needs rest, and we facilitate the importance of the rest by making the person feel tired and not interested in interacting with others. And interleukin 6 causes hyperalgesia. We can block toll-like receptor 4 with low-dose naltrexone. And you know that naltrexone has been used for drug addiction, but in doses of 50 milligram tablets, which are the lowest tablets available commercially. In my practice, we start with 0.1 milligram, 100 micrograms, and we slowly titrate up to a maximum of approximately 6 milligrams per day. If you use very small amounts of naltrexone, you do not block the mu receptor, but only block the toll-like receptor number 4. When we have central sensitization, we have a phenomena of pain causing pain. We have a corollary phenomena called diffuse noxious inhibitory control, now known as conditioned pain modulation. And here we have pain inhibiting pain. So the classical experiment for diffuse noxious inhibitory control is putting someone's hand in ice water and then inflicting some sort of painful stimulus, let's say in the opposite hand with a pinprick. And when DNIC is working, the sensation of pain is diminished when you have a severe pain. So pain covers pain. And insofar as treating patients, if you eliminate pain from one region, they may become conscious of pain in another region. And that's because of the DNIC phenomena. So when we're treating patients and we deactivate one muscle, that then they may say, well, now I'm feeling more pain on the opposite side or in another part of my body. And there's a constant need to reevaluate this patient if you're treating pain that originates in their muscle. We have dysfunction in conditioned pain modulation in certain chronic idiopathic pain states such as irritable bowel syndrome, temporomandibular joint dysfunction, and fibromyalgia. So I want to tell you how I became involved with muscles, and to follow on from what Roger presented earlier, I was introduced to Hans Krauss when he was 85 years old, and I was much younger as well. And Hans asked me what I did, and I told him I taught patients how to live with chronic pain. We had a pain management center at Lenox Hill Hospital. I had a floor, and we had a very large staff, and we taught patients that despite persistent pain, you could still have quality of life. And Hans asked me, well, that's strange. Why don't you just get rid of it? And I said, well, you know, it's chronic, and, you know, sometimes pain doesn't go away, and patients, you know, they have their pain and they still can have some quality of life. And he said, yeah, but how do you know that it's not coming from muscle? And he already assumed that I hadn't really understood how to evaluate or treat muscle, and he was correct. And I told him that many of my patients were unable to do much of my program. And when he asked me what kind of exercises you do, I said, we do the low impact aerobics. And he said, oh, that's silly. How could anybody do any kind of aerobic if they had low back pain? And he was correct. And I asked him, what exercises you do? And he said, I do exercises based on my studying 3,700 patients for 4.5 years, and then giving those exercises to 300,000 people at the YMCA. So I was very impressed, and he offered to come to my office and see a patient or two with me, and I accepted, of course, but he was the new guy on the block, so I was going to present him a patient that I thought was impossible for anybody to treat. So I chose a patient who had arachnoiditis. She had 2 Panapaque myelograms, and if you know about the old days, Panapaque was oil-based, and we had a high incidence of arachnoiditis, and she had 2 back surgeries afterwards. She was on round-the-clock morphine, 60 milligrams oral morphine. She went through the pain program and only got about a 50% reduction in her pain. She was still totally disabled. And we examined her, and Hans found 4 muscles. They were bilateral, quadratus lumborum, gluteus maximus, piriformis, and we considered the tensor fasciae lata and vastus lateralis as a muscle group. And he said, if we treat these muscles, I think she'll be much better. And I didn't think it was possible because I saw her cauda equina being squeezed by granulation tissue on the post-myelogram CT. And we proceeded, however, to treat her. We could only do 2 muscles a week, and we did that. And after 4 weeks of treatment, her pain was gone. She stopped morphine and went back to work. So this was an epiphany, and it was a life-changing event because it forced me to say, how many patients do I have a diagnosis based on imaging and absent the evaluation of soft tissue, where the soft tissue may indeed be the immediate cause of the pain. This patient still had arachnoiditis, but that wasn't the source for pain at that moment in time. So Hans had 4 reasons functionally why patients develop pain. They were tension, deficiency, or deconditioning, spasm, and trigger points. And let's go through each one of them one at a time. And tension is a voluntary sustained contraction of striated muscle. So it can be from emotional stress, or it could be from physical stress. It could be like a repetitive strain injury. And the examples would be low back pain, temporomandibular joint dysfunction, or nonspecific neck and shoulder pain. And we did not have an animal model for this. I mean, we've been able to observe patients and get histories telling us that the patient indeed had a stress and the pain went up. But in 2015, Hoheisel in Germany with his group immobilized a rat for 1 hour. And after 1 hour, the rat was released. But for 12 days afterwards, measurements of the dorsal horn neurons representing the lumbar spinal region were increased in activity. So their resting potentials were lowered, spontaneous activity was up significantly, and this lasted for 12 days with 1 hour of immobilization. So we now have a model for stress causing back pain. Hans defined deficiency as weakness and or stiffness and in the low back for key postural muscles. And he developed the Krauss-Weber test, a very simple test, 5 movements that give us a host of and a wealth of information concerning weakness and stiffness of key postural muscles. We have the same phenomena in the upper body evaluation that Hans developed, and he went on to then create his exercise program where he taught 300,000 patients twice a week for 6 weeks, and then studied 12,000 of those patients with an 80% success rate in reduction or elimination of back pain, and then had a subset of patients who had previous back surgery, and there was an 82% success rate in diminishing their pain as well. Spasm. So spasm, as we know, is an involuntary contraction, sustained contraction of a striated muscle. And the model that we know is the pain, spasm, pain, a feedback loop. We have the muscle fiber here, which is perturbed, and group 3 and group 4 afferents are stimulated, going back to the dorsal horn of the spinal cord. And then the theoretical model goes that we then stimulate an alpha motor neuron to the homologous muscle, and then go back to the muscle, and then have this vicious loop that keeps going on. And it's actually incorrect. And it was demonstrated to be incorrect in 1991 by James Lund, but unfortunately it's still not seeped into medical knowledge. And James Lund initially was the Lund hypothesis, and then now called the pain adaptation model. And indeed, we do have a group 3 and group 4 fiber that's stimulated to the, and synapses with the dorsal horn neuron, but there are internuncial neurons between the alpha motor neuron. One of the internuncial neurons goes back to the homologous muscle, and this is inhibitory, whereas the internuncial neuron for the antagonist muscle is facilitative. So we get suppression of electrical activity in the muscle that's a source of pain, and we get enhancement of electrical activity with spasm and pain in the antagonist muscle. And for example, if it was the adductor magnus that was the source of pain, the patient may actually present with pain in the region of the iliotibial band or the vastus lateralis. So it's incumbent on us when we see a patient with pain or spasm to investigate all of the muscles in that region of the body. And trigger points. So trigger points are tender nodular areas in the muscle associated with the taut band and may refer pain to proximal and distal muscles. If we look at the biochemical milieu of the trigger point, is elevations in substance P, calcitonin gene-related peptide, bradykinin, serotonin, and various cytokines. It's the work of J. Shah. There's hypoxia in the region and acidic pH. And we make the diagnosis by pain to palpation. And the phenomena that is put forth as the reason for the formation of the trigger point is the energy crisis hypothesis from Mency and Simons. And there's initial sustained calcium release from overload of the muscle from the sarcoplasmic reticulum, where the calcium is stored in the cell. We get sustained contraction of actin and myosin, causing local ischemia, increased metabolism, an energy crisis, which gives us not enough energy to reuptake the calcium and giving us this vicious cycle. And what happens is that the constricted blood vessel inhibits the flow of blood, delivers less oxygen. Hypoxia is a sensitizing agent to the nociceptors. It gives us impaired calcium pump function. The calcium pump extracts the calcium ion from the actin-myosin complex. So therefore, we have ongoing contraction of the muscle with resilience in the area and trigger points. The problem is that we're identifying this trigger point with palpation, which is unreliable because we are testing a sedentary versus an active muscle. The nociceptors are not predominantly in the muscle tissue, but in the entheses, as I said before, the attachment sites of the muscle. And we don't know when we palpate if we're palpating tenderness in a primary muscle or a referred muscle. And we don't know in terms of the layers of which layer we are palpating when we press. Actually, there's 16 muscles that move the shoulder girdle, so knowing which one of them is the source is a challenge, but we need to understand that any one of them may be the reason that someone has shoulder pain. I developed an instrument where I can electrically identify the source of pain, and if in this patient, if it turns out that she had pain coming from the trapezius, actually, we would want to know specifically, because if we're going to inject, we want to inject where the attachments are on the cervical, thoracic spine, the spine of the scapula, and the acromion, as well as the occiput. So let's get back to our case. 43-year-old male, married, muscular, mildly obese, and we did a range of motion of his shoulders with a 7-inch deficit in internal rotation of his right shoulder versus left. Often that's associated with sensitization in the infraspinatus and teres minor. The cervical spine also had limitations in rotation and bending, and the temporomandibular joint was unremarkable. When we looked at his muscles for tenderness using stimulation and palpation, we had a number of sensitized muscles, but we did find the teres minor and the right infraspinatus. And the next slide is of the injection technique that I use. It's called muscle tendon injection rather than trigger point injections, because it's very thorough and it focuses on the attachment sites. And you're going to see the infraspinatus was first injected, and then I'm going to be injecting the teres minor. And here are you can see the blood from the infraspinatus injection. You can see the outline of the infraspinatus. And here I am on the border of the scapula, the lateral border, and I'm injecting into the attachments, and we're going to look for the twitch response. And you'll see it shortly. And this is a sensitized muscle. And when we when we inject like this, we do not have to re-inject. So it looks very aggressive, but the outcome is profound compared to dry needling or to just injecting a spot somewhere in a muscle. So in this case, we found central sensitization, and we used low-dose naltrexone, and his diffuse pain got better. He had anxiety and stress. We used a low dose of Zoloft, which was 25 milligrams. He had stiffness, and we gave him the Krauss exercises and education on proper warm-up. He would just go into his resistance training and never stretch beforehand. And his altered muscle tissue was treated with muscle tendon injections versus trigger point injections. And his pre-treatment brief pain inventory was severity of 8 out of 10 and interference was 7 out of 10. 6 months later, after his last treatment, severity was down to 2 and interference was down to 1. And we looked at 95 patients who had been treated in 2011. And these patients had failed back surgery syndrome, radiofrequency ablations, epidural steroid injections, trigger points, and prolotherapy. Prior to our treatment, we were able to get follow-up on 67 of the patients. And in the pre and post muscle tendon injection survey at 77 weeks, the average severity pre-injection was 5.5. Afterwards, at 77 weeks, was 3.9, whereas the interference was more dramatically reduced from a 6 before injection to 3.2, 77 weeks after the last injection. And these are the references. And so I don't know if we have time. If those of you can stay later, I can take questions. But otherwise, if you have to leave, you can send any questions to me at my email, and I'm happy to respond. So thank you very much.
Thank you, Norman. This was a really nice summary of the science behind muscular pain, or the presumed science behind it. I guess we're not 100% sure yet, and how you translate that into your clinical practice. Are there any questions? I would have a question. We've been working together for a number of years, and you've dealt with a lot of really complex patients. In this particular case, just as an example, so this patient had some cervical pathology that probably didn't really explain, however, his particular symptoms, and he probably had surgery. But why is it that a lot of these patients who have some kind of cervical or lumbar pathology develop muscular pain? Is there a relationship somehow, or is it totally independent?
Well, in terms of these studies, it looks like at the initial presentation, the bulk of the patients have soft tissue pain, and it's not part of our paradigm to assess them. So the examination does not include an evaluation, and certainly not a diagnosis of tension, weakness, stiffness, spasm, or trigger points, and the specific identification of the muscles. So the whole idea is to start to include this in our educational paradigm, which is what we're doing at the Spine Center. So we are training, but it's a long, hard road.
So the idea in this particular patient would have been, if he had been assessed from the very beginning for muscular pain, the cervical spine would probably never have been an issue. It would not have required any particular surgical treatment. You would have treated him for the muscular pain from the very beginning, and hopefully he would have been pain-free and happy.
Well, we don't know that, but we can say it's one of the possibilities that he may not have needed the surgery. So ideally, it would be perfect if we could assess patients for the presence of muscle pain prior to surgery, and then we could screen out those patients who are going to have pain that's coming mostly from soft tissue. But we also have patients who have successful surgery where the radicular component of the pain is gone, but yet they're left with axial pain, and that becomes a real challenge. And quite often, that is from soft tissue. So It doesn't have to be either or. It really is complementary. And I think it's a matter of having a more comprehensive model of where the pain comes from, rather than thinking there's a silver bullet and it's either the surgery or it's the exercise or the PT, but rather it's a combination. That makes more sense to me anyway.
So I think it would be really important then to incorporate the particular examination for muscular pain from the very beginning, not only in pain medicine, physiatry, but also for surgeons, residents, fellows, us attendings. So from the very beginning that we really pay attention and examine these patients or screen these patients appropriately. I think we should probably come up with some kind of algorithm to do that. I think that would probably be very helpful. I know you've been doing this with Neil and with his fellows, but we should probably expand that and get us neurosurgeons more involved in that as well.
That would be great. I'd be thrilled to do that.
Are there any other questions or comments? Now, what was Willie Nagler's relationship with Hans Krauss? Willie Nagler was the head of physiatry here at Cornell for many years. He's retired now, but he worked with him, or he trained under him, or what was the relationship?
So the fear was from the Kennedy people that Hans was old and that he would die, and they wanted a backup. So Willie Nagler trained with Hans, but actually never treated Kennedy. So
Hans Krauss did. I don't know if you mentioned that. But
yeah. So Hans Krauss treated Kennedy, got him all better for the most part, and Kennedy was going to start a spine center when he was assassinated. So what I'm presenting now wouldn't be unusual, you know, wouldn't be a dog and pony show outside the box, but would be standard of care, because Kennedy was never better in his life than after being treated by Hans.
All right, Rupa.
Yeah, that's really wonderful. Thank you so much. I think everyone here has learned a lot, and we could probably go on for another hour, but thank you for your time. And if anyone has any additional questions, wasn't able to answer them, just go ahead and email me, and Dr. Marcus has kindly offered to answer any questions that come our way.
All right, bye-bye.
Great, thank you everyone.
Thanks, Norman, again.
Thank you. Thanks, Raj. Thanks.